Nick Majerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. Part 2 of Obstructive Sleep Apnea. Snoring is boring and can seriously damage your health. It's presented by Andrew Spector, Assistant Professor of Neurology at Duke University Medical Center in Durham. It gets into the detail of how you can stand up an obstructive sleep apnea clinic at your practice. Have a listen and I'll give you some words at the end.
Top Med Talk.
There are a whole bunch of home sleep apnea tests on the market, and I didn't realize just how many until I started doing this. But there are catalogs of these things, and page after page of different manufacturers who make these, and you have to determine what type is best. So we have different examples. I have different examples on the slide here from different manufacturers. The one on the far right, that's unique in the group. That's called a WatchPat device, and that just goes on your wrist and your finger. The others have belts that go around the chest to monitor the chest excursion from breathing effort, a pulse oximeter on your finger, and a nasal cannula that goes around your nose to monitor your breathing. So a traditional home sleep test will have about 4 different channels that it's monitoring, whereas that WatchPat, that unique one, has fewer. That comes into play based on reimbursement for the test because they're not monitoring as much. So which type you choose can be influenced by the insurance coverage. You want to know, is it simple? Because you're sending this box home with patients, they're going to have to figure out how to hook themselves up when they get home. So you can't have a device that's too complicated or it's not going to give you a good result. And then if you plan to use the auto-scoring, you want to know from each manufacturer how reliable their auto-scoring is. Other questions to ask: how are you going to get this back? And this is a logistical trouble. Duke is famous for terrible parking. It is a major hassle to park. So people don't want to come back a second day and drop the box off. That's just too much effort. So how can we make that convenient? We don't want to add barriers to this testing. So if they're going to be bringing it back a second day, how can we make that easy for them? What about shipping it back? And then there's an additional cost associated with that. But we certainly have patients who are coming from surgery from 2, 3, 4 hours away or more. Can they take the box home and ship it back? Another question, is it cloud-based? We ran into issues with this because Duke Compliance wasn't so happy with the idea of certain information getting uploaded to a manufacturer's cloud for storage. So you've got to look out for whether or not your institution is going to say no to anything where the data is shared outside of your institution. What about theft and damage? These machines do hold up really well. It's shockingly rare for us to lose one of these machines, but it does happen. So what are you going to do if you need to replace the box? What kind of guarantees and replacement policies do the manufacturers have? Who is the patient going to call overnight? You really don't want your 10, 15, 20 patients, however many you're churning through a night, to be calling your sleep lab who's trying to run their in-lab sleep studies with issues with their machines overnight. Is there an 800 number they can call where they can go straight to the manufacturer? That's a big deal so that you're not creating extra burden on your sleep techs. What about medical contraindications? It turns out that home sleep apnea testing is not actually indicated for every patient. If you have physical or cognitive disabilities that would prevent you from actually being able to hook yourself up, then you may not want to do a home sleep test. The other population, that WatchPat device that goes on the finger and the wrist that I showed you in the previous slide, that doesn't read well for certain cardiac arrhythmias. So you wouldn't want to go with that device necessarily if there's a population you couldn't use it on. The flip side is it's much more tolerable for patients. They like that device a lot better. So then you have to decide, do you go for the ease of use or the universality of use? You even have to make a decision on battery life. I mean, this is getting really detailed here, but this matters. So if you get 20 devices for your clinic and they're rechargeable, do you have 20 outlets to hook them up to so that you could be recharging these every day? Whereas you could just pop in the batteries. Now, if you do that, you've got an additional cost. You've got to buy a bunch of batteries. It's 2 AA per night for all these things. So you've got to factor that in when you look at the financial modeling. And then lastly, does it integrate with your EMR? And someday I'm insistent that Duke will be able to integrate these home sleep tests with the EMR so the data will transfer directly. We don't even have this yet, but we are working toward it because that will make everybody's life better. Next logistical hurdle is getting them a CPAP. And if any of you have seen how this works, it can take weeks. Depending on your insurance in North Carolina, for example, if you have Medicaid, it can take a month from the time a CPAP is ordered to a time a CPAP is provided, because that's how long it takes in Raleigh for them to review it and approve it. So there are major delays sometimes, and so we want to expedite this. To do that, we have to figure out, okay, well, who's looking at the results of the sleep test and ordering that sleep study? We have our nurse practitioners in the perioperative clinic doing this. Do you want to use an in-house DME? Do you even have an in-house DME, a durable medical equipment company? We don't. We refer all of our CPAP orders outside. So we need to partner with these companies to streamline this process and make sure that they're ready for a massive influx of additional patients that we're picking up from doing the perioperative sleep clinic. Can you even embed them right in your clinic? Because that's really great if you can do it as a one-stop shop. So if you can envision, they come in for screening, they get their home sleep test, they bring it back the next day, it's interpreted on the spot, and they go right next door to get their CPAP. That's 24-hour turnaround. Now, that's ideal. Is it possible? A lot of that is based on your compliance department, because there are rules about whether or not you can embed an outside agency in your hospital. It's a little more flexible if you're doing this at an outpatient clinic than a hospital-based clinic. There's a little bit more ease in having them show up right next door, but maybe not in your clinic. So there are rules like that, but in its most efficient form, this could in theory be done in 24 to 48 hours if you've really got it streamlined. But even at our best attempts, CPAP will not always be available on time. Like I said, in North Carolina, Medicaid takes a month, and there's nothing we can do to make that faster. That's an issue in Raleigh, and we have no control over that. There's actually no evidence that you need to delay surgery over this. You can manage patients the way we've been doing. What we're doing with the reduction in narcotics and the increased monitoring, that does help. And so we have no study that says that you have to have your own CPAP ahead of time. You can use hospital CPAPs, and the hospitals all have them. So you can order a CPAP for your patients, and you can get them through the post-op period that way if you have to. And then finally, how are the patients going to be transitioned away from perioperative sleep clinic? We have it set up so that the first follow-up is right there in the periop clinic. Even though they're post-op, they do one follow-up right there. And that has to do with insurance rules. Medicare, for example, requires that all patients who start CPAP be seen by a provider within 30 to 90 days after they start CPAP to document that they are benefiting from CPAP and they are compliant with CPAP. And so some provider needs to see them within 30 to 90 days. And the most efficient way for us to do this is to go back to the same provider who ordered it, they certify that it's been done, and then they can go on and either follow up with sleep clinic or with their primary care doctors, and that decision can be made at the time, depending on how complex the sleep apnea is. If everything is going great and there's no need for a sleep consult, they really don't need to come and see us if they're doing well. So that's sort of the process that we use to get our sleep apnea clinic put together. I want to talk a little bit about how this fits financially. This is how I see the balance sheet. There are costs and there's revenue. On the cost side, of course, there's the space. You've got to somehow provide the overhead for the clinic, staff, and that includes your front desk staff, your financial staff, the providers, and the sleep testing equipment. You've got to acquire a whole bunch more home sleep apnea tests than you otherwise probably have in your sleep department right now. On the revenue side, every sleep test is reimbursed with a technical fee and an interpretation fee. If your model is that the hospital collects the technical fee, the physician collects the interpretation fee, then the physicians can actually profit that way. On the other hand, some are using an RVU model, so then you can globally bill for a sleep test, and the technical and interpretation fees are rolled into one. The hospital gets that, and the physicians would get RVU credit for the interpretation. Clinic E&M is a tricky question, and we are actively sorting this issue out because In the perioperative world, a lot of the funding comes from these bundled payments, and you may not be able to bill a separate E&M code in this setting. But if you take ownership of this condition, if you're managing sleep apnea now, that actually can trigger the ability to bill evaluation and management codes. So you may be able to work out with your billing department how to make this work so that your nurse practitioners and PAs can actually legitimately bill an E&M code for this. After all of that, the bottom line is still affected by the downstream benefits, by reduced length of stay, reduced complications from the surgery. And that's not going to necessarily show up on your clinic's bottom line, but when you're negotiating with your administration, you don't want to ignore that as a potential, it's not so much revenue, but it's a cost saver, so it functions the same way on the balance sheet. So who would you need in terms of staffing? That's physicians to interpret the studies, probably a medical director to oversee the clinic, APPs to staff the clinic, and then respiratory therapists and sleep techs. There's an overlap in what they do, but the way we've set up the clinic, there is an embedded sleep tech right there. So after you screen positive and you go next door, you can get your home sleep testing equipment right there on the spot. A medical assistant can actually be trained to do that just as well, but we wanted a respiratory therapist or a sleep tech involved so that patients who already have sleep apnea but may not be compliant with their CPAPs can actually come in and get a consult, and that's more than we would expect a medical assistant to be able to do. But the respiratory therapists and sleep techs are really good at triaging CPAP problems, fixing mask leak, and other tricks of the trade to improve CPAP compliance for the patients who aren't necessarily needing new sleep tests, but you'd still want to get compliant with CPAP before their surgery. And then on the staff side, you do want a financial person who knows how to get these sleep tests approved. Because you're doing mostly home sleep apnea testing, it's actually really easy. Very few insurances would actually say no to a home sleep test. They're markedly cheaper than in-lab sleep studies, and virtually all of the commercial insurances now and Medicare will really pass through with very little fight any request for a home sleep test. You also need the clinic staff and administrative oversight. So the financial considerations for the home sleep test, we talked a little bit about this already. Right now, Medicare is the only insurance that reliably pays for in-lab sleep testing. Blue Cross, Cigna, Aetna, Humana, United, they're all sort of enforcing home sleep testing first. And so in some respects, that is something we can take advantage of because we actually really want home sleep apnea testing. That's really fine for our purposes. We don't need full in-lab sleep tests. So the fact that they're now approving these is actually advantageous for us, even though it is technically less revenue for the hospital because they don't get to bill a big procedure like an in-lab sleep test. It's faster, cheaper to go the route that the insurance companies are actually pushing. And Medicare is the only one right now that doesn't object to an in-lab sleep test. Medicaid, I can tell you only North Carolina. I don't know all the Medicaids around the country. In North Carolina, it's a very bizarre situation. They want us to do an in-lab sleep test and don't actually allow us to do home sleep tests. I think that's unique in North Carolina, and someday that's bound to change because it's just so out of line with what everyone else is doing right now. But the costs for the home sleep tests are dependent on either how many devices you buy or lease, or how many studies you do. Depending on which manufacturer you go with, some will bill you per study, and some will bill you just for the owning or leasing of the device. And so you have to look at your financial modeling and figure out which would make more sense for you. And then like we talked about the batteries, those have to be factored into the cost. There's a cost to replacing the nasal cannulas for every patient. So there are consumables that have to be built into your budget also. Whether or not you buy or lease the equipment is debatable. I think leasing makes sense because there's bound to be technology improvements over time. So I don't necessarily want to have 40 home sleep apnea tests that are 10 years old. So when you lease them, you actually can get upgrades every few years. So to me, that makes sense, but it might not make sense to your financial model. And then a lot of the home sleep testing equipment actually include with their package interpretation. You can sign up for that or not. So if you don't have enough sleep doctors and you want to do this even outside the world of sleep medicine physicians, you can actually outsource the interpretation of the sleep tests to the company, and they've got sleep doctors on staff who will churn through these for you. And if you do have a big sleep division, I imagine they won't be happy if you outsource this work. But if you don't need to be dependent on having that, because you can make use of this feature of the home sleep tests. From a CPAP side of things, CPAP titrations are, in my mind, very much overutilized. We're in an era where auto-titrating CPAP is really pretty good, and in many cases better. So instead of doing an in-lab sleep study where we hook you all up to all the wires and we add the CPAP and then manually titrate, we just use a broad range on an auto-titrating CPAP and let the CPAP figure it out. CPAPs now upload all of their data to a website. We can track them from home. We can adjust their settings. In the office with remote monitoring of their CPAPs. There really isn't a huge value for most patients. There are exceptions, and some patients should have in-lab CPAP titrations, but they're usually your sickest patients, and a lot of them may not even be able to have surgery anyway, so you may not see a huge number of these. But for patients with severe heart failure, and that's a New York Heart classification of 3 or worse, severe COPD, neuromuscular diseases like advanced ALS, or people on high-dose chronic opioids who are prone to developing central sleep apnea, or those who just have central sleep apnea on the home sleep test. Those are people you'd probably want to observe on CPAP in the lab before you gave them an auto. But virtually everyone else can go straight to an auto-titrating CPAP, which means you're going from a home sleep test to an auto-titrating CPAP, and the patients never need to actually go into the sleep lab. And I know that this breaks a lot of years of dogma, but from an efficiency standpoint and a medical standpoint, it is really just as good. The bottom line financially is that home sleep apnea testing is probably not going to be profitable for you. Your goal is to see if you can make it break even. And breaking even is fine when you realize that medical outcomes are better. And if you can do something that's revenue neutral or cost neutral and improves health outcomes, then why wouldn't you? The interpretation, if you're doing enough of them, physicians probably can actually make a little bit. No one's going to get rich on interpreting home sleep tests, but it's probably going to be a net positive from the physician side of things. If you're doing more in-lab studies, if you're doing in-lab PSGs and CPAP titrations, that will no doubt be positive. The reimbursement is high enough that will definitely work in your favor financially. And then if you can figure out how to get your clinic to be billing in the E&M world, that would be a benefit too. So it's not just the bundled payments. And of course, I said this before, the outcomes also drives your bottom line. So you won't see it necessarily in your clinic, but you are going to be saving the hospital money and complication rates. So to summarize, sleep apnea does increase the risk of perioperative complications. CPAP does improve that, so this is something that we're very motivated to do. We can also improve long-term health, and this is what I love so much about sleep medicine. It's that we can take something that's just air pressure, not even drugs, and improve quality of life because they feel better, improve health outcomes, both short-term and long-term. And there aren't many things that you can do all of the above. So that's one of the great benefits of this. We're using this perioperative space a lot like what Dr. Davis was saying in the smoking cessation. We're using this to capture a whole bunch of patients who might not have ever been captured before because now they're motivated. So we can capture them now and treat their sleep apnea for years to come and greatly improve their health long term. I didn't give you a lot of specific instructions. What I gave you was a lot of questions to ask because institutions are different, insurances in your state are different, but this is what I would consider to be the procedure by which you could go about setting up a sleep clinic. And you do all this so that you can sleep well at night, knowing that your patients are in the best hands. Thank you.
Top Med Talk.
So this piece was taken from the hugely successful EBPOM-USA Masters course, a Perioperative Care Practicum, which took place in Atlanta earlier this year. I mentioned at the beginning of the podcast we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website topmedtalk.com, click through to events and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMTIFAD18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMTIFAD18. So TMT IFAD 18 is an easy way of remembering that. That's live from the Monday on the 19th. You can get onto there, put your question in early and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website topmedtalk.com and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website topmedtalk.com and download all of our podcasts, our entire archive, whole back catalogue, many hundreds of valuable podcasts with incredible information within.